Je vais remercier l'Institut Jérôme Leyen and the President of the Scientific Committee, Marc Tassé, pour votre gentille invitation to participer à votre journée cliniques internationales. Je suis très heureux d'entendre collègues and partager time in these 2 days in Paris. Now in English, because in Spanish could be difficult for you, no? Then, when we speak about quality of life, we are speaking about a concept that has more than 3 decades of development. It started 3 decades ago as an idea that was what had interest in the person, an idea that along the time was going to be a measurable construct. It started with an ideographic focus, thinking only in the specific person, and then it evolved the concept to a multi-system perspective that we are going to explain. The last decade we are speaking about a model of quality of life. That model mainly focus on what to do, what is important for the person with intellectual disabilities. But this model, in the last years, we are speaking about how to improve quality of life. Not only what is important, but how can you improve, what are the main strategies to improve quality of life. Then also, we have many publications related to these ideas, but now we are just writing and doing some publications developing a theory of quality of life that are more serious words, no? A theory that, because we have a lot of research previously done, and we need to do more research to confirm and validate the hypothesis of the theory. But we are in that moment, we evolve from the idea to a theory that is, that want to help to change professional and organizational practices of people who work with intellectually disabled persons. Well, the model that I'm going to explain has been mainly developed with Bob Shallock, probably a famous psychologist living in Seattle but working around the world. We developed 2 books describing the model and the ideas that we have related to quality of life, and there are also many research articles, publications that can give the main ideas of the concept. But quality of life is a concept that has been many different researchers work on it. No? In the beginning, it was more than 2 decades ago. Was very good research teams in Wales, in UK, in Scandinavia, in Canada, in Australia, and in USA too. And also in the last 15 years, there have been research teams in Belgium, Holland, Spain, and different countries, at least the ones that I know. We developed this model starting from the results of research of many different researchers then. But we developed a concrete and specific model that is being applied in many places. The main ideas are we work with a multidimensional approach. We understand quality of life with 8 different dimensions, and we work defining and explaining and measuring and improving strategies with these 8 dimensions or domains of quality of life. But quality of life also is a socio-ecological approach. We give importance to the environment, to the supports, and to the work of people that are directly related with people with intellectual disabilities. Then our vision is inclusion. Our vision is personal-centered planning, the strategy to develop this, and support paradigm is the way that we work. The main point of quality of life is that it's a concept, an idea, a model that integrate all of these advances or paradigms of the last years to work together to improve practices mainly. Well, we started years ago doing a scientific review of literature in the way that to understand what were the main dimensions that researchers around the world were working on. Then we did a extensive analysis of scientific research in health, social services, education, aging, mental health, and well, we did a previous validation of the 8 dimensions proposed by Bob Salok in 1996. But then, and after this, we did work in different countries to understand what are the main dimensions. If you speak about quality of life, your quality of life, my quality of life of a person with significant disabilities, cerebral palsy, autism, intellectual disabilities. Even now in brain injury, we are working on this. We are speaking about 8 dimensions, that is emotional well-being, personal well-being, material well-being, social inclusion, interpersonal relationships, personal development, rights, and self-determination. These are the 8 dimensions of quality of life. And these are the ones that we measure, and we develop strategies to improve the life of the people. Quality of life is the sum of the information related to many of these dimensions of the person's life. But after the scientific review of literature, the review of scientific literature, we were having focus groups and discussion groups in different countries, the States, Spain, Central Europe, in Belgium and Holland mainly, Taiwan too, different countries. We just were developing indicators that were useful to measure the dimensions of quality of life, these 8 dimensions that I told you. Then this was a kind of qualitative work, previous work, and after that we developed cross-cultural validation in more than 20 countries, 4 continents around the world, Europe, America, and Asia, and Europe, America, Asia, and Australia, not in Africa. No, you know. Then we obtain data. We apply scales for to families of persons with intellectual disabilities, to persons with intellectual disabilities, and direct care professionals, psychologists, educators, and other people working directly with these people. Then we publish that research confirming the 8 dimensions, starting to know the main indicators that were useful to measure quality of life. And then, well, after that, the main conclusions were that quality of life is, we speak with these anthropological expressions like ethic and emic properties. Ethic is universal properties, and emic is the importance of contextualize and on different cultures or groups, target groups, how can you measure or understand quality of life. Then we get some kind of social validation of the model, and we start to develop quality of life questionnaires to go one step ahead in the research that we have done. Now, the quality of life current definition that we have is a multidimensional approach composed of these core domains that I told to you. There are other models that could be useful too, but any model on quality of life should have different quality of life domains that gives you an idea about the quality of life of the person. You can think on you, and then you can think on any disabled people when they are young or when they are adults. It's the same. But the measurement of the quality of life could be different because of the items should be important for the group of people and the other personal and environmental characteristics that you can find. Then we identify what are, and we should yet do research, but we already identify many personal and environmental factors that influence results on quality of life. And these core domains, I told you, that are the same for all the people, and with this current definition, we did different research approaches. We validate different models to understand quality of life. We apply classical test theory with confirmatory factorial analysis and structural equation modeling, and also with item response theory in some parts of the research. Any scale, psychometric scale, well developed today, the validation should be with confirmatory factorial analysis, like telling you that your hypothesis about the main subscales or the main parts of the contents are right. No? Well, we did many different applications, and the best fit of data are the 8-dimension model. The first 8 quality of life factors. Was the first order quality of life. But you can find too in the analysis some second order factors like independence factor, social participation and well-being. Data also fit well with this hierarchical structure of quality of life. But our experience in working with organizations, with professionals in many parts of Spain, Latin America, and European countries is that the 8-dimension model is the best one to applicate and to get information to help people. But you can work also reducing the information to these 3 second-order factors of independence, social participation, and well-being. We have many research done with different authors in different countries and with that validate these results and confirm the ideas that I'm telling to you. But now, going to a second step in my presentation, I would like to speak about how to improve quality of life, not only what is the concept or how and how has been the evolution, but now to speak about what are the main ideas for improving quality of life. We are emphasizing now these 3 strategies. Although we can speak about many things to do, and we are going to say I'm going to say some of the concepts that could be useful. We emphasize that if you want to change, to improve, and to facilitate life for people with disabilities, with intellectual and developmental disabilities, one of the key issues is to increase personal participation. One of the keys of the work should be the empowerment and the increase of the participation of the people for anything that you do with them. No? And then I'm mainly speaking of teenagers and adult people. You're speaking about educational life. Life is more dependent on the work of the family and of the professionals working with them. But even them, when they are adolescents, you must work with them in increasing the participation for the future life, the life project, building the personal development of the person, helping them to decide, to choose, to select. Well, personal participation is a key issue for organizations to increase, to measure and to plan and to develop ideas. Then the other strategy, or main strategy, is establishing effectiveness and efficiency of individualized supports. The task of the organizations, the task of professionals, is to organize a good support, individual support program based on data, based on the knowledge and the clinical knowledge too of the person, and then you should organize individualized support that they need. This is the other strategy. Increasing the effectiveness and efficiency of the supports will result in an increase of the quality of life and the results on quality of life. And the other is opportunities. Many times because of segregated traditional institutional issues, mainly generalized in Europe yet, in most of the countries, but all around the world. But in Europe, still more, for example, than in America, more segregated alternatives yet that is difficult to change. Opportunities for personal growth and development should be related to community issues, to participation in the local community, the normal place of people. Then personal participation, individualized supports, and new opportunities. Organizations should give new opportunities for growth and development and inclusion of the people with disabilities. These are the 3 strategies that we are emphasizing. But we are working with a systems perspective on individual quality of life improvement. We are just after years of work, we started to focus on individual issues. We say, well, one important word in quality of life is personal outcomes. We say, what can you say that somebody is working well? Tell me about the personal outcomes of each client or consumer. Tell me how do you know and how do you improve that personal outcomes. That's the key issue to know if you are doing well. Your organization, your professional practice, your family support, you should increase these personal outcomes. But many years we were only speaking about this, but the conclusion, working with organizations in different places, has been that our conclusion, I mean, when I say our is both Salamanque and me in the writings that we have is that if you don't change organizational work, you don't change professional practice. Then the focus should be we must change the way that organizations working with people with intellectual disabilities are doing, the general way of doing that. There are good examples of organizations already doing innovations and changes, but this is not general. We should change this. We should do some transformation of organizations. Our last book in 2012 that has been translated to different languages, not to French, but it's English, Spanish, and now to Italian probably. And our focus is how to change organizational practice to increase personal outcomes of consumers or people. But also we think that public policy should be related to these changes. We work with a concept that we think that is important, is alignment. One of the problems that you can find is that you can do good innovations working with people with intellectual disabilities, professional, any kind of discipline, or the team of different approaches to work and to help people, but you need organizational work and you need new public policies thinking on results, on inclusive advances, and financing personal outcomes and advances in personal outcomes. We tell this because in Spain, like in other countries all around Spain, we are not so centralized like France is, but we have 17 different regions or communities with different legal norms sometimes. It's a really crazy country for that. But in all of these 17 regional communities, you have the problem that usually you can work for inclusion or working for quality, helping to increase quality of life of persons. But perhaps organization is not in the same path, and then you have problems. But usually public policy is not following the same model of socio-ecological approach, environmental work for community approaches. Then in Spain, like many other countries, the government pay you for having a person in a place that is a specific place, it's a segregated place in employment or in residence, and it's difficult to develop normative that can incentive and give incentives and help you to develop community approaches. But this is a problem all around the world. I know much better in my country. But when we speak about alignment, we say individual, organizational, and public policy policy work should be related. We call that is vertical alignment, should be going to the same outcomes, similar vision, and should be connected, should be a synergy among these three parts. And then we work with a logic program model, like you can see in the slide, and we are thinking on results at the end. There are different organizational results, different public policy results, and different personal outcome results. But the three of them should be related and coherent in the way that are being worked. Well, we work with this idea. Alignment is an idea that comes from the industry. The problems of many companies in industries is that they don't align the main functions of the industry. The main functions in our work is assessment, intervention or treatment or support. The groups that do this sometimes are not related and not connected. This is horizontal alignment, to relate and to align main functions of one organization to work for getting better results. Well, alignment is an important concept, but we have been we have developed many tools and instruments to measure quality of life in different countries. I'm going to explain you some of the last ones that we developed that are the best because they are with the best psychometric properties and the best methodology that we have been developing tools from 15 years ago, and then we have now the know-how to do it about this. But you can find quality of life scales with psychometric properties, because you can have more than 100 or 200 quality of life scales in the literature, but many of them are clinical scales, like consensus scales or the experience of some groups that could be of interest, but it's difficult to generalize to other groups, and you are not validating your conclusions. No, I mean about psychometric properties of quality of life. You have in different countries different measures, but the ones that we develop, and we have a French version in some of them, the complete French version, although it's not validated yet. The last two ones that we developed in Spain has been what we call Escala Inicofias. Is like you say if scale is enough. It's the first letter of that, because it's complex to translate. But this scale has two subscales. One is a self-report, and the other is report of other persons about the quality of life of the people. Then you can use and compare and use information for different goals. Inicofias scale is with the best psychometric properties, confirmatory factorial analysis and structural equation modeling. And also the San Martin scale that has been developed just the last year, has been published, and now is a scale for significant intellectual disabilities. The first scale in any language with psychometric properties, confirmatory factorial analysis of them. Because some of the scales, good scales, have only exploratory factorial analysis, then you can see, well, it's okay, but the stability of the scores, that is important to compare a long time the person, to work with aggregated data, to understand what are the priorities in the dimensions to work with any person, you cannot do in the same way. But this scale, the San Martin scale, we have the French version. At the end, I will tell you the URL of the, if any of you have interest of this. I will present this also in Paris in 2 months, because it has got a lot of attention of people working with significant disabilities, autism, cerebral palsy, and intellectual, severe and profound traditional classification of intellectual disabilities. We have the translation of the manual and the scale, in this case to French. It has been done by not professional interpreters, because my institute is the only one in Spain with psychosocial approach, CINICO. We have no money, you know. We only get competitive employment projects. Then our situation is not, it's good because we work a lot, but we work because we want to do it, not because we have support from the government or others. We get competitive projects in Europe, in Spain, or in different parts, or with private foundations. Well, how we develop these scales? How we develop these scales is, I don't want to tell you anything, but we used to do the work that we usually do is review of research, scales that others develop, clinical scales, psychometric scales, if you have some of them. We review that, and then we start to do focus group, discussion groups with direct care professionals. Now we are working, for example, in brain injury, and we had this last week in Madrid, not last week, on Monday, I had a meeting in Madrid with psychologists, neuropsychologists, rehabilitation medicine professionals, and they coordinate occupational therapy, social workers, and other people. And then we were discussing just how to understand the way that we are going to measure quality of life. They give us the experience of work that they have. Then usually we work with a team that is research team and direct care team, and then they participate in the first steps of defining contents, utility of the contents for the people, no? And then we do a systematic Delphi study with 3 months of work with 12 or 15 experts with more than 10 years working with the population, and then we refine what are the contents of the measurement. Then we do a pilot study, psychometric study, and all the factorial, confirmatory factorial analysis, structural equation modeling, and anything. There is a systematic development of the scale. It's not simply a consensus about what is important. What are the main parts of a scale? You should have good items that should be observable. They should have sensitivity to change. They can change, you can improve them. They should be important for that dimension. They should be included in the appropriate dimension. This is conclusions that we get from the Delphi study and statistical analysis of results of the opinions of experts. And then, well, we have different items like this that you can see here. These items, we have a Likert scale system of answer from 1 to 4, the frequency that this item is included. For example, in this scale, San Martin, working with professionals was very important, more than personal variables, environmental variables, like knowing emotional, having knowledge, the stuff of the emotional behavior of the person as usually he or she behaves, developing secure decisions about, well, they include many, and we refine contents of many items related to environmental variables, because some of the work is to refine, to simplify, to specify the idea to be understood easily for many different persons. At the end, we have direct scores. We also do a mathematical transformation of two zeta scores that you can compare. You can take clinical decisions when you get the profile and index of quality of life. You can see where can you emphasize your work, how are you work. You can examine what are the main activities that you are doing and what are the results in personal outcomes on quality of life. You should compare this data, can give you a lot of information to take clinical decisions of individual support plan in different domains. But you can also compare year by year. Quality of life don't change every 3 months. At least you need 1 year, 1.5, even 2 years sometimes to do important change in quality of life. But you can compare the data because you have reliability and validity of the scale, and you can do that. But you can also work with grouped data. Well, we are working using quality of life like a framework to integrate also support needs and quality of life. Sorry for this slide that is too many contents inside, but mainly we are working with, when we say that quality of life is a framework to integrate support needs, we are meaning that you put in the left column the 8 first order quality of life factors that we are working with. Then you can integrate in each of these domains qualitative and quantitative information that gives you ideas about what is important for and to the person on quality of life, and then you can develop support strategies and individual support plans to improve the quality of life, and then you can evaluate at the end the impact of the support strategies. Based on this kind of complex presentation slide, there are many specific formats in different countries, on different organizations, in Spain too, but you can see also in Holland and in Belgium. For example, this is from Holland. At the end, direct care professionals need 1 page to know about what is important in quality of life for the person that you are working with, in residence, in employment, or in community. If you don't reduce to 1 page all the information we have about experts in physicians, psychologists, occupational therapy, rehabilitators, any kind of rehabilitator, if you don't simplify that to 1 page, probably your expert work is nothing to do with the results you obtain in the life of people. Then you should simplify. This is not easy, but you should synthesize information in a kind of format or protocol that allows the direct care person who is not specialized to know what are the specific things these 3 months from September to December are important to work in the daily support that they can give the person. We are doing, finishing the time, but we are working with different organizations in Spain doing changes using this quality of life approach. We use it to measure personal outcomes and to develop organizational innovation and change to transform the way that usually we work in segregated places. We have in Barcelona, for example, they were working with comparing individual data. It's a crazy idea, but this was done to select risk people that were with the lowest levels of quality of life, like as the scale was measuring, and trying to know why was this situation to take decisions on organization. Other groups, like in Madrid, a big organization with more than 1,500 people served, they are already now in a step ahead, but comparing the information coming from the self-report and the report from others, trying to get information to be used in the individual and organizational plans. They use aggregated analysis of services, programs, units in this big organization with more than 20 different services and centers. And there are other organizations doing using quality of life to change the way that they used to work for more inclusive approach, using data. That is the main point, using data to decide and to improve and to develop the individual support programs. Even in Catalonia, we develop an analysis of all the organizations that they have working in social services. It was financed by the government of Catalonia 3 years ago, and we developed a profile of the organization results on quality of life, and they can compare the individual results with the service results, with the organization results, with all Catalonia results. This is public policy. You can do public policy using data. But well, we did that job, and then the government changed, and these things are funny things in public policy. When the government changed, all the things changed, and then but we did this job that is important in advance. And the last thing we are just developing now is in internet free. The last year we are working in a way that is we get the money and the projects, and we put free without cost our scales in internet to be used by anybody that want to use. Not doing money, that is important. You want to generalize tools, systems, and work. You should be free. People can use it without paying anything, and this is our idea. Then this has been developed, coordinated again by Bob Shalok and a team from Belgium and Holland, Taiwan, and Spain. We have done the first scale that is focusing on organizational transformation, and we work with these 4 perspectives that you can. We work in a simple scale with 20 items that are focusing on customer, on organizational growth, financial approach of the organization, and internal processes. This is related with the idea that I told to you that we should change the way organizations work. We should change the way that they are thinking, how they plan. They should give more effectiveness and efficiency of the support they give them. We are working on this, and lastly, we are relating quality of life with the rights that the United Nations Convention of 2006 proposed, and France, Spain, and many other countries, more than 140 countries, signed around the world this Convention of Rights of Persons with Disabilities. But then we think that the quality of life is an emerging paradigm. You can just is the way to measure if the rights are being applied or not. Convention is not only to change laws that we are doing in Europe or in many other countries, I think, but it's also applying in individual and organizational places ways to increase the rights of education, to participation of and any other rights to that person had. And then we are working now in a study in Europe with focus groups. Previously we have done a Delphi study between Holland, Spain, Italy, different countries, trying to get common or consensus on the main indicators of the articles of the Convention of United Nations from a quality of life perspective. Then this will allow us in the future to develop a scale to measure this, and that could be useful for examining results of quality of life. Then, well, one of the questions that you can have is this, no? And sometimes when I speak in Spain, I speak usually about quality of life, or in other countries, I say, well, how can we change organization? It's difficult to change the segregated path that we have from many decades, because it has been the way to do it. It's the way to get financial help from your government usually, no? It's possible to change that, because sometimes it's difficult because there are many things to do, no? But I give you ideas from other people that sure you know, Einstein and Steve Jobs, no? And Einstein say that you must move, no? He says, well, the world is a dangerous place to live, no? Not because of people are evil, but because of people who don't do anything about it. You can find this in organizations sometimes. Better not to move, better to stay like we were always. No? In this field, if you don't move, if you don't do innovations and change, if you don't work with data now, if you don't base your decisions in data and in new approaches, probably you are a dangerous person, and Einstein said. And also Steve Jobs give good ideas about thinking different, no, to change the world. Well, these are the, I finished, but these are the URLs that you can consult. Mainly the inico.usal.es. You have, but any of you that have interest, you have my mail there. You can write a mail and I can give you URLs to get the scales in French or in English. On Italian, we have in different. In Japanese, we have also some scale, but there is no validation usually. But at least you have the translation of items to know that there are some people with interest starting to do validation, but I'm not sure of that. Thank you.